The first speaker for the day is Dr. Duru Shah. Dr. Duru Shah is the scientific director of Gynac World Mumbai and is a consultant to the Breach Candy Hospital, Jaslok Hospital, and Sir Harkisan Das Hospital in Mumbai. Over the years, Dr. Shah has been engaged in several social awareness initiatives such as Growing Up, the Urban Adolescent Empowerment Program, Kishori, the urban slum based adolescent empowerment program in Dharavi, and a rural mental health program, Save the Mothers. Currently, she's focusing her attention on combating sexual abuse, especially in young girls. Towards that end, more recently, she was part of a groundbreaking campaign on gender violence issues, Breaking the Silence on Violence by the NGO Sneha. She is a recipient of many national and international awards, the most prominent being the Distinguished Merit Award for Service Towards Women's Health, awarded to her by FIGO at the World Conference in Rome, Italy in October 2012. She's the first Indian to have ever received this prestigious award. Over to you, Dr. Shah. We're really happy that you're here today.
Good morning, ladies and gentlemen. Thank you very much to the Foundation for having invited me today to speak to all of you. My area of this doesn't work. Okay. My area for today's discussion, as suggested to me, was supposed to be on the recognizing and responding to child sexual abuse, which is a medical practitioner's perspective. On 16 December 2012, it changed India, we all know, that a 23-year-old paramedical intern was gang raped by 6 men in a moving bus and left to die on the streets of Delhi. This is a video actually of a CNN news report which showed how the young people talked about, can I have the video please? How the young people were out into the streets and how they managed to get
Government data shows a rape is reported every 22 minutes in India. But since the December gang rape of a student in a moving bus in New Delhi, women's rights activists say the Indian consciousness has changed forever.
The idea is to show that how young people had brought the whole thing to the forefront and brought this issue up where everyone got involved in the management of sexual abuse. Can I have the voice sound off?
Here because this is an everyday issue. My father calls me up 6 times in a day just to check where am I, where am I, where am I.
New anti-rape laws are being debated in Parliament, but women's rights activists say when discrimination is endemic, change will not come easily.
So what does WHO say about sexual abuse? What WHO says in a narrower definition is that the WHO multi-country study was conducted and they very, very simply put it down as it is physical force to have sexual intercourse when a woman does not want to, if she's had sexual intercourse when she did not want to, but because she was afraid of what her partner might do, and lastly is forced to do something sexual that she found degrading and humiliating. It could be rape within marriage or it could be rape within dating relationships. It could be rape by strangers or acquaintances. It could be unwanted sexual advances or sexual harassment at school, work, etc. Or systematic rape, sexual slavery and other forms of violence which are particularly common in armed conflicts. It also includes sexual abuse of mentally or physically disabled people, rape and sexual abuse of children, and customary forms of sexual violence such as forced marriage or cohabitation. When we look at the health consequences of sexual violence, we automatically come to reproductive health because it is a reproductive system which gets affected. There's a lot of gynecological trauma to the extent that there's been forced penetration wherein it could be causing a lot of injury to the perineal and vaginal area and to the anal area. It could cause a lot of strictures, it could cause a lot of fibrosis so that later on in life the girl may have difficulty even to have normal sex. It could cause an unintended pregnancy because the girl may be ovulating at that point in time and she could get pregnant. And hence she would go ahead with an unsafe abortion. The reason I'm bringing up this issue is because every girl does not go and complain to the police. Every girl does not go to the hospital. Most of the girls stay back at home. They realize they are pregnant only when they are quite advanced in pregnancy. And then they end up having an unsafe abortion, that is, they do not go to the medical professionals, but get it done in a very quack type of way, which can lead to death because of infection. It causes sexual dysfunction. As a matter of fact, as a gynecologist, I come across a lot of young women who have difficulty in having sex within marriage. And they are so scared, they are so frigid that they find it extremely difficult for years together. And when you go into their backgrounds, you realize that in some point in time in their childhood, they had been sexually abused. It may not necessarily be that there would have been penetration, but it could have been some kind of assault. So, sexually transmitted infections, which include HIV, hepatitis B, are diseases which are for life because we don't have treatment for them, and this they could pick up from the person who is molesting them. And the last is the traumatic fistulae. Those are the worst of the lot because that if there is penetration in a very young girl, it would lead to a kind of a sort of a what you say connection between the vagina and the urinary bladder, or a connection between the rectum and the vagina, so that she's constantly leaking urine from the vagina or constantly leaking stool from there. This requires surgical intervention, but in the meantime, the girl is smelling so foul that nobody wants to go next to her. So, this is something which happens with health issues. The next is mental health, wherein there's depression, there's post-traumatic stress disorder, which I'm sure a lot of you here who are counselors and psychologists know very well about it. There's anxiety, sleep difficulties, somatic complaints, suicidal behavior, and panic disorder. Since this must have been covered, I will not go into this. There's behavioral issues wherein there's high risk behavior, there's because of the unprotected sexual intercourse, early consensual sexual initiation, and multiple partners, alcohol and drug abuse. It's basically that girl wants to take revenge on around the world. She's so upset that it could lead to problems both in the girls and the boys who have been sexually abused, wherein there's a kind of a high risk behavior which causes problems for them in future. There could be fatal outcome with death from suicide, wherein she wants to just end her life. There are pregnancy complications where she could be pregnant and she could just get on with her pregnancy without realizing it. We had a young girl, 14, who got pregnant because her parents went for a bypass surgery. This was many years ago when the cardiac bypass surgery was not very commonly done in India. Her parents went abroad and she lived with her family, a joint extended family, and her cousin sexually abused her. She didn't realize she was pregnant. Her parents came back 3 months later, and by the time they reached me, she was already 6.5 months pregnant, which is illegal for us to do an abortion, and therefore she had to continue with her pregnancy, go away from the city, live in some hill station area, come back for the delivery somewhere outside Mumbai, went there, delivered her, and then the baby was given for adoption right away. So the question is that it tends to happen within families, and therefore pregnancy complications do occur because they do not reach the medical practitioner. There's unsafe abortions leading to death because of infection, because of the abortion being carried out in a space which is not very hygienic. The HIV infection could lead to AIDS and then death. It could be murder during rape or for honor, which we see a lot in Hindi movies, and which are the facts of life if you go into the interiors of the country where the girl is killed only because of honor, and infanticide of a child born of rape. When child is born of rape, so many times a baby is just killed as soon as it is born. And who are these culprits? More than 95% of sex offenders are relatives, neighbors, and friends. Hence, a majority of the cases go unreported, and amongst those which get reported, 90% do not get justice because of lack of evidence. Now, if we look at the number of cases which are lingering around in courts, which have not yet received any justice, are more than 25,000 cases which are still lingering in court as of this data. To some extent, we can say that this lack of evidence is due to failure of the medical profession. 95% of the victims do not get justice because doctors do not document correctly, nor do they collect the evidence correctly. They continue to use the two-finger test as evidence, which is now banned by the Supreme Court. The private sector of the medical profession does not even want to get involved because of the issue of going to court and wasting a lot of time hanging around courts. This insult after assault is what is said about the two-finger test, and I'll tell you what the two-finger test is about. 2 days after she was raped, this is a news item, 2 days after she was raped, the 18-year-old girl lay spread-eagled on a white sheet at a public hospital. Her underclothes were removed by a nurse and 2 male doctors arrived. She went stiff as without a word they started examining her. All of a sudden, 2 gloved fingers went deep inside her vagina and she cried out in pain. Silent and aloof, they merely wiped their fingers on glass slides and left. They neither asked her permission nor explained to her why they did what they did. And this is the two-finger test, which is widely performed across India because one of the forms wherein you fill the data talks about the two-finger test. And what it really means is that the doctor examines the patient, the victim, with the 2 fingers, and if the 2 fingers go in easily, which shows that the vagina is quite open, it means she is habituated to sex. And this is what they write, 2-finger PV done, patient is habituated to sex. But does that mean that a woman who's a virgin always has to be raped? Could it not be a woman who's already married or probably already sexually active and then she gets raped? So in that case, what happens is when this kind of a documentation is put in, then it causes a kind of a thing for the lawyers to think about is that probably that this person has low moral values. And this is how this whole and what you call as the unscientific and invasive form of privacy and dignity has been looked upon by most of the countries, and they have scrapped it, and now even India has scrapped it. In the wake of the Delhi gang rape case, the survivors appeared in silhouette on TV and talked about their trauma at the hands of the doctors. This is because there are inexperienced doctors, which form the huge problem as victims get traumatized further and vital evidence is lost. And the reason for this all is because in 1997, the law stipulated that only formal female doctors handle medical examination of rape victims. In 2005, all registered medical practitioners were legally empowered to handle such cases. But these changes have introduced more physicians to these examinations, means there are more doctors available, but unfortunately, most of them have not been trained. So, what we are trying to say is that it's not the hymen which we need to focus upon, and that is what is actually happening today. We must remember that the hymen can be torn even because of excessive, rigorous physical activity such as cycling, riding, and swimming. And if there are old tears, we don't need to document those. An examination of the status by its type, edges, what it looks like, etc., is absolutely not necessary. There's at the moment, the current scenario is where young doctors who have not been trained in this are overemphasizing on the presence of injuries in medical examination. There's poor history taking. There's a mandatory police requisition which has been asked for, and therefore people, doctors, suppose there is a young girl who comes into a private practitioner's clinic. The first thing they tell them is, this is a legal issue, you please go to the police station or you go to a public hospital where the police will come in and talk to you. And that's the beginning of the end, because then the girl does not want to go to the police station, she does not want to go to court, she just needs help for her medical therapy, which at the moment it tends to get neglected because the girl needs to go because it's a police case, as you may say. The Human Rights Watch report, which mentioned that more than 100 experts, including doctors, lawyers, police, women's rights activists, signed a joint statement arguing that the demeaning test does not provide any evidence that is relevant to proving the offense. And therefore, in 2013, the Supreme Court of India has ordered the removal of the test from the reporting document. I'm happy to tell you that I was one of the doctors who signed on that document which went to the Supreme Court, and I'm so happy to see that this two-finger test is now no longer on the document, which is now being prepared by the government as a national standard. Hopefully, in 2 weeks from now, we will have a regular form available through the government, through the national government, which will empower all the doctors all over the country to have the correct form of documentation, which will not be going against the victim. FIGO is the international body which calls up of all gynecologists all over the world, and it has national standards for the respect of these rights of women. And it calls upon all members of the profession to respect and protect women's rights in their daily practice, including their sexual and reproductive rights. There are two important guidelines being prepared by FIGO. I'm one of the members of the ethics committee of FIGO, and I have actually stimulated them to prepare these guidelines, because these guidelines will then go all over the world to all the doctors or all the gynecologists practicing everywhere. And we have created one guideline on healthcare professional responses to violence against women. What are the response of the doctors against when they see a woman with violence? And second is conducting medical forensic examination in a case of sexual assault. So for the last 6 months, we have been working on these, and hopefully these will be ready in July this year and will be ready for dissemination all over the world. What FIGO recommends is that there should be direct training programs with continuing medical professional education or university based or comparable courses on management of sexual abuse. If it gets involved into the university program, and therefore if there are any educationists here, this is something we must remember. If we include it in the medical curriculum of the medical students, then there should be no problem. But the current situation is that we do have a training during the medical curriculum, but it's so limited and it's so little that, and no importance is given to it, that what I studied 40 years ago in my forensic class, I may not remember 40 years later. So this is something we need to upgrade. And second is preventing sexual abuse through education of young people. So violence against women is something where FIGO recommends that we should train the medical professionals on how to diagnose the type of violence, how to inquire about a history, how to collect forensic evidence, how to be sensitive to a young lady when we are doing all this, and have the basic knowledge about violence and relevant laws and appropriate attitudes amongst healthcare providers. They also recommend that there should be clinical care which should be woman-centered. We must treat the woman, as not only treat her as a piece of evidence which we have to collect some part of it. And we need to have a first-line support which includes consultation in a private, confidential place, being non-judgmental, careful, and be respectful whilst listening, and increase the safety for patients and their children. We must help patients access available resources, and therefore what this consultative meeting is doing is putting up a list of all the sources where doctors can refer to, would be very, very useful in helping to disseminate this information amongst the medical professionals. Care for victims should be integrated into the existing services rather than stand alone as separate services, and we must give priority to service delivery at the primary care level and health care providers unable to offer the first line support. That means if a young girl is pregnant and she wants to have the abortion done because of what she's gone through, there are doctors who would find it against their religion that they do not want to do an abortion, or there may be doctors who do not have the facility or the training. And these doctors have been recommended that they need to transfer or refer those patients to the correct places so that the victim gets all the help she needs. FIGO recommends also that women presenting shortly after sexual assault should be offered protection against sexually transmitted infections and emergency contraception so that she does not get pregnant within 120 hours. So we need to give her antibiotics against any kind of reproductive tract infection, and we also need to give her emergency contraception. If later the contraception fails, the woman should be offered abortion services according to applicable law in that country. We also need to give long-term care, emotional support, information, etc. So there's a lot of things to be taken care of, but at the same time, every country has its own laws. And these laws mandating reporting evidence of violence have to be followed as per the country. It specialized rape crisis centers are recommended by them, but if they are unavailable, private locations should be provided. Consent needs to be conducted, consent needs to be taken before medical forensic examination and all tests, and whilst respecting their choice, should stress advantages of examination. There are many sexually abused girls who are not willing to undergo an examination, not willing to have evidence collected. We must respect their wishes. At the same time, we must try and counsel them that it's extremely important for them to have the evidence in place so that in future, if they ever need to use it, they have it documented. So these are the things which we've been talking about, and the two-finger test is something which I brought up in the meeting, and I said this is something which must come on our recommendation, and they have put it up over there that the two-finger test is now discredited and should be abandoned and prevented. Complainants should be informed that refusal to undergo an examination may have negative implications. Victims should be offered appropriate care, and these are basically all the recommendations which FIGO gives, which are followed by the professionals or the gynecologists all over the world, and therefore they bring out all these issues regarding consent and examination. And finally, they say that every gynecologist who is responsible for conducting medical forensic examination should be trained, should be equipped, and willing to present evidence in court. This is a duty towards sexually abused women of all ages that professionalism requires to be discharged. FOXY, which is our national organization of gynecologists, of which I was the president in 2006, we created a film on sexual abuse called The Body and Soul, which is at the moment available on YouTube. It was created in 2006 and reprinted in 2013. And I have been very, very particularly worked up about this issue. And in 2006, I made this film, which I carried all over the country, and I wanted to educate the doctors on how to collect evidence. And because I realized what was happening in the courts, and we created a new cell called the Violence Against Women cell. We have created a position statement on this, on violence against women. And at the same time, we looked at what were the attitudes of the members of our Gynec Association. And if you look at this survey which we conducted on about 316 members or gynecologists from all over the country, we asked a few questions and tried to find out what are their attitudes. And the answers which we received from the 316 were that they came across women who had suffered violence either from husbands or from family members. This is more like domestic violence. Once a week was 28%, once a month 21%, once a year 36%, and hardly ever in almost 14 to 15%. Means 85% of the women are undergoing some form of domestic violence, as the gynecologists report. And out of which they say, do they routinely ask patients coming to the clinic about sexual abuse or domestic violence? And 76% said, no, we do not routinely ask. And actually that's quite understandable, because we are not supposed to ask actually straightforward, are you having domestic violence? But when we examine a patient and when we look at her and we find any evidence that probably this woman is being abused, then in our own way we can very sensitively ask whether such a problem is existing. Then we ask them whether do the patients disclose that they are facing some form of violence or abuse, and almost 50% of the doctors said yes, women do disclose that they are having a problem. And then we had how are these women managed, out of which we did not receive an answer. Out of 316 questions asked, people asked this question, 111 did not answer this question, but approximately 8.7 said we do not manage, but the majority of them talked about referring them to a public hospital. So this is what I'm trying to tell you, that most of the private practitioners would refer the patients to the public hospital, which the patient does not want to go. So this is the scenario at the moment. We have written a chapter, actually at the personal level, I've written a chapter in a postgraduate book of gynecology, which is on violence against women, a universal challenge, which is something which not many people write in books. This was basically to increase sensitize the doctors that something like this we need to look at, and this book is read by mainly postgraduate OBGYN students. We worked on the ethical committee recommendations, as I mentioned to you. We've been working at various NGOs. I've been working with Childline, Majlis, Neha on this subject. And at the moment, we have created a forum for addressing violence against women, where some of the NGOs have been participating. We have brought in the police, the judiciary, and one of our meetings was attended by 2 members of foundation. And we are working at developing a workshop on this issue and trying to educate the doctors. Hopefully by the end of this month we'll have the workshop ready with modules from each one of them, so that this workshop can be carried all over the country, training the doctors on what they need to do, basically related to how to manage a patient who comes to them and how to proceed from there. Most of them do not know what next to do. So then the other issue about FIGO is that we must prevent sexual abuse by educating young people. And this is a strategy which we have tried. We have trained we ran this program for 10 years in schools all over the country. We had 1,000 gynecologists going all over, and we talked to more than 5 million girls, talking to them about their reproductive and sexual health and how to prevent a bad touch, how to understand or recognize what is a good touch, a bad touch, what happens when you are sexually active without using a contraceptive, what are unsafe abortions, what are the sexually transmitted infections, etc., etc. We also ran an urban slum program called the Kishori program in the slums of Dharavi. And what we did was we empowered the girls between 15 to 19 years in the same way as we did in the schools. Because in the slums, you find that the girls are mainly school dropouts. By the time they reach puberty at 12, 13, their parents keep them at home till they get them married off by the age of 15 and 16. So the intention of this Kishori program, which we also ran for another about 9 years, and this was to empower them with knowledge on their reproductive and sexual health. We also gave them vocations so that they are financially independent and they can stand up for their own rights. Because if a girl is not financially empowered or able to support herself, she's always going to be dependent on the husband, and therefore she will not be able to stand up for her rights. The day she is financially independent, she can stand up for her rights, and this is something which I've always believed in and always done with my own girls. We also did the Suprabha Ganga Yatra, which was a very massive program, 3.5 months of walking for 2,400 kilometers along the length of the Ganges, which is the worst area which has the highest maternal mortality and the highest incidence of problems occurring for women. And there we walked and we created health awareness on more than 1 million people on reproductive and sexual health, conducting camps in all the villages along the way. In the cities, we conducted something what we call the Foxy Youth Express, where we went to second-tier cities and third-tier cities, discussing contraception, discussing HIV with all the young people from colleges. All our doctors brought in the young people from their local cities, and we discussed, and the sessions never ended. Lecture went on for half an hour, but the discussion went on for 3 hours. They have so many questions, and there's no one to answer them. So this is something which was an agenda which we did, and we did more than 20,000 youth all over the country. Now, the national protocols and checklists for examination of survivors of sexual abuse are being developed at the national level, and these will be soon available to all of us, which will help the doctors. And there is a protocol wherein we talk about how to evaluate a case, how to, what is to be done, how to estimate the age, how to get the consent, and what are the treatments we need to offer to these victims. The POXO Act, as we know, all of us know, in 2012 has come up, but there are certain issues which we as doctors are facing, and the mandatory obligation to report the matter is something which is bothering us, and I'll explain to you why. The mandatory for police to register an FIR is also something which we need to actually discuss. And the third is the Nirbhaya Act, in which again one of the things which is mandatory for doctors approached by the survivor to collect evidence. This is something we want to take it all over the country and make our doctors understand that it is mandatory for them, if they are approached by a survivor, that they need to collect evidence, and if they don't, then they can be held up against held up by law as a criminal offense. So the two issues which I have about the new acts is one, that if as a doctor, if I have a young girl who's 16 and comes to me with a pregnancy, and she comes to me for a termination, she's come to me and as a doctor, is it mandatory for me to report to the police? It's not that she's been sexually abused, she's voluntarily had sex with her boyfriend and she's got pregnant and she's come to me for an abortion. Because she's less than 18, do I have to inform the police? That's my concern. And secondly, if a sexually abused girl does not wish to report to the police, what should be our stand as medical practitioners? The way forward is sensitizing doctors, updating doctors, creating awareness about the current law, and training of medical students, change in the medical curriculum, uniform protocols. These are a lot of things which we all need to do even as doctors, and a beginning has been made. Violence against women is perhaps the most shameful violation of human rights. It knows no boundaries of geography, culture, or wealth. As long as it continues, we not claim to be making real progress towards equality, development, and peace. This was mentioned by Kofi Annan, United Nations General Assembly, New York, way back in June 2000. Thank you very much, ladies and gentlemen, for your kind attention.
Hello, Dr. Shah. To on this, it's okay. My name is Vasudha. I just wanted to understand that what happens to the young boys who are sexually abused and or even anally penetrated, or what kind of medical examination and what kind of provision is there in this whole setup that you spoke about, or even violence against women cell. So suppose we expand it to children, so that boys are also included. And
Yeah. No, I totally agree with you that boys need to be included. But usually, because I'm a gynecologist, I'm talking the ladies' point of view, because we do not normally see boys in our practice. But yes, as a medical practitioner, even if a boy comes to me, it's my duty to examine the child and get all the evidence which I need to collect. The question is that this law applies to everyone. The second thing is the examination also. There's a checklist which will be coming up soon, which will involve the boys also. And thirdly, usually the pediatricians are the one who handles the boys. So usually if it's a pediatrician who would be, talking about it, they would be talking more about boys till the age of 12, and then they get very uncomfortable with the girls after the age of 13 once they've reached puberty. So what I'm talking about is what we have done at the gynecological point of view. But yes, everything applies to boys equally. There's no issue on that.
I just want, I'm little ignorant that, so I'm just saying that suppose like yesterday some cases, was discussed where sometimes pediatricians are not able to, uh, uh, meaning understand or treat the extent of injury, suppose.
Yes.
So then in that case, what happens? Even young boys do go to gynecologists?
See, normally they don't. That's what I'm trying
They
to
don't,
tell you.
okay.
So young boys would normally go either to the family physician, who's their, their GP, who's looking after the family, or they would be taken to the pediatrician. That's the normal process. But this module which we are preparing will go to everyone. So it's going to contain for boys and for girls whatever needs to be done, and it'll go to all kinds of doctors. It's not going to go only to gynecologists. It'll also go to the pediatricians, and it'll also go to the other fields like the general practitioners, the IMA members, etc. So it will contain the module on how to take care of boys too.
Doctor, here.
I'm sorry, there's so much of light. Yeah.
Thank you, Dr. Shah, for
Thank you.
standing up for the girl child and all the work that you've been doing with the youth and sensitizing them, and even your writings in the PG books. That's an awesome way to get it into the system. So you talked about the workshops that you're working on, which is going to release at the end of this month, and also the checklists that are going to come out. So one question that I have is, does that lend itself to online training? Where I guess my broader question is, how can we scale that up really quickly through either online trainings or like putting it on a CD to send it out to all the doctors in every city and village in the country? What are your thoughts on how we can best and quickly scale it up?
Yeah. See, once we have got, normally whenever you start something which will go finally out into the public space, you need to be sure what you're doing before putting it out there. So initially the plan is, this is our plan. Initially our plan is to get the module sort of put into place where each stakeholder puts in their comments and their inputs so that they are the experts, like say the police. We have asked them to put up a module onto what really they think the doctors need to do when the case, when a victim reports to them, and what is the next step they need to do, what is the kind of process they need to follow. So I'm giving an example. So once we have that module in place, we will pilot test it first. We will test it within a few cities and see whether it's working well. Once we know it's working well, we then take this module either to the state government or we take it to the national level and ask them whether they can put it into the state plan. Because what happens, this is my observation, because when I was the president of my gynec association, I was dealing a lot with the Ministry of Health. We did a lot of stuff at the level of the ministry. We did a lot of stuff and we produced documents. But what happens is health is a state subject. Now whether sexual abuse comes under what heading, I'm not very sure. If anyone here knows, I'll be happy to know. But health comes under state subject. So when the center sent out all those documents to the states, half the states didn't even know that the documents have arrived. Because when I went to Maharashtra government health minister and I asked him, I said, what's happening about this project? He had no idea. He called the NRRH director, that's the NRRH section which deals with all this health, reproductive health. He didn't know what was happening. So the books must have come to the state health ministry. It must be lying somewhere. So, when these documents get done at the national level, we also need to promote them at the state level where health is concerned. So suppose, does anyone know here where it comes under, the sexual abuse? Does it come under health? Can I have that information?
If I may.
I'll just wait for her to.
I'm Persis from Majlis. Clarification is that health is a state subject, but 164A, which deals with medical examination, is under the CRPC. It deals with medical examination of a rape victim. So whether it is medical examination under the criminal law amendment or under POCSO, that is on the concurrent list, which means basically that the state as well as the center can legislate on it. If there is a contradiction between the state and the central legislation, then the central legislation will prevail. But if the state legislates on it, then it is permitted.
No, the question is not of the legislation part. The question is of, suppose the government has to carry it forward.
Right.
Who carries it forward?
The Ministry of Health will carry it forward, but with regards to the protocol, for example, now we are coming up with the new proforma that is supposed to come up.
Correct.
That would be a proforma for examination of sexual violence cases. That would be under 164A, which is under the CRPC,
So
which
that
is
would
on
be
the
a national.
concurrent list. So it gets slightly complicated, but
So we wonder whether we take this program forward with the center or whether we should go to each state. That is the question.
the answer would be preferably to take it forward with the center, but the state has to implement it. And if
That's
the state,
exactly
yes.
the problem.
And the thing is that if the state already has a program which is in contradiction with the center, the question arises is when there's a contradiction, then what the center has will prevail.
Okay. So the plan would be, thank you, the plan would be to take it further through the government, is to take it where, to get the plans rolling out, number one. Second thing is to go to the educational ministry and see that it gets part of in-training service for all the doctors who are graduating out. So they get trained right there with the new laws in place. And what we have suggested is that if it's at the university level, then, see to it that something on the subject gets included in the examination paper so that the students have to read, because if they think it's something which is, oh, it's only 2 marks, forget it, I'm not going to waste my time reading this. But if it's given enough importance in the curriculum, then yes, the students will read about it, and probably so. And then of course take it online and promote it through social media. There's so much more one could do, but unless one has things in place, you cannot go ahead. But that is the plan, to take it further.
Thank you.
Ma'am. Ma'am.
Yes.
I'm Chandrika from Arpan. I had a question that when we are talking about guidelines and disseminating it in through various processes, do we have something in place to monitor how it has been used by various stakeholders? Like, I can put it online and there will be doctors who can go through it and use it. But for some time, there be any monitoring process of how the doctors or the gynacs have been using this guideline, and how is it interpreted, and how long do you think will this take for monitoring, till the time we are sure that okay, now monitoring is not required and it can be.
No, see, it's like this, that when it becomes mandatory for any doctor, it's not necessarily gynecologist, it can be even a GP. When he knows that it is mandatory for him to collect evidence if the survivor has come to him, then if he doesn't do it, it's criminal and it's against the law, and he can be hauled up for it. He will automatically do it, because if you know it's something against the law, you don't need to be monitored. Like, say, if I know it's wrong to steal, nobody needs to monitor me to make sure whether I'm stealing or not. I know that the law says if I'm caught stealing, I'm in trouble. So idea is to just educate the doctors on the subject, that it is wrong if you don't do it, because till today it never existed. In today it was optional. Like, if a survivor comes to you, you could send the survivor to the public hospital and say, go there and they will take care of you. And they were taken care of. It's not that they were not taken care of. But in a public hospital, what happens is there is no separate area where the young girl can go or the young boy can go, have enough confidentiality, privacy, because it's such a busy place. There's not enough time. The young doctors don't have enough time. They're so overworked. See, I brought up the issue of the medical profession not being able to go ahead, but when you go to a public hospital, I mean, the kind of work as a junior doctor we all have put in, it's like days of being awake all the time. I mean, you may not even get time to sleep, you may not get time to eat, you may not get time even to go to the washroom. So the question is that you're so overworked and there's not enough space to see those kind of patients, that it's not the fault really of the doctor. It's a question of having the infrastructure in place. Once in a public hospital, there's a separate a crisis center available, where there's a separate room, separate doctors available there. Yes, things will happen. That process is also on at the moment in Mumbai, where the municipal hospitals are having this. In 3-4 hospitals, they are trying this out, and I think Majlis is also helping up with the Rahat project, if I'm not mistaken. So they're doing it. Everything is happening, but we need to move faster. Now, what I'm talking about is targeting the private sector. We need to target the private sector, which is almost 80% of the doctors. So we need to target them, and honestly, we don't need to monitor them. We just need to sensitize them and tell them from 2012, this is the law and you better do it.
Thank you.
Hi, my name's Christelle. I work for an NGO called Dilse in Cochin, and I have a home called Tejas Home for pregnant teenagers. I have a couple of questions. A girl becomes pregnant, she goes to the police station, they take her to the CWC brings her to us. A medical examination has perhaps not yet happened. The police, they come and pick the girl up to take her for a medical examination. They always take her to the government hospital. Is that necessary, or can it be to any doctor of our choice?
Now it's any doctor of your choice according to the new law.
Could it be a midwife also, because we work with?
See, at the moment I don't think they are recognizing midwives in this country, but I know abroad it is acceptable.
No, it's only registered medical practitioner. Okay.
In this country, yes.
Okay. Also, for below 18 for an abortion, is it correct that they need the signature of a guardian? And what if the girl does not have a guardian? Can we sign on behalf of the NGO that
I
she's...
suppose so, if she doesn't have a guardian, but the legal part of it, I think it would be better you ask the legal. Majlis can answer that question.
Okay.
But if the girl doesn't have a guardian and if there is an NGO who's willing to take a guardianship, I suppose that should be acceptable.
Okay, and
I don't know whether legally it is okay.
CWC, okay, fine. And the last question, if the pregnancy is between 3 months and I think 20 weeks is the maximum,
Yes.
is it correct in
Yes, we
saying
can
that
terminate a pregnancy up to 20 weeks.
2 doctors need to agree on that?
Yes.
Is that correct?
If it is above 13 weeks, 2 doctors need to agree on it.
20 weeks is huge, no? 20
Sorry?
20 weeks is 5 months, literally.
Yes, till 5 months you can do it.
Is that specific to India? Because I'm not sure.
No,
that
abroad it's done even if there are
Also-
situations where a termination of pregnancy needs to be done. Like say, if there is a patient who's got a child who's abnormal, which you pick up say at 30 weeks or 32 weeks, and you know that this child is not going to survive or have a good quality of life, they allow termination even till 34 weeks and 38 weeks. But they have a very sensitive way of doing it, a very nice way of doing it. Unfortunately, in our country, I'm sure all of you have heard of the case where the lady found out that she had a very, very abnormal child only at 24 weeks of pregnancy. But she was not allowed to terminate it. And therefore, she had to carry on the pregnancy. Fortunately for her, she had a preterm delivery. But otherwise, she would have had to carry on. So 20 weeks is where it's legally allowed.
Thank you.